for what will hopefully be an engaging panel on when is a clinical decision support tool fair. My name is William Parker. I'm an assistant director of the MacLean Center, an assistant professor of medicine and public health sciences at the University of Chicago. The way this is going to work is I'm a pulmonary critical care doctor and a health services researcher and a data scientist, as well as a clinical medical ethicist. So I'm going to explain what we mean by a clinical decision support tool. We're going to review basic statistics of classification, which is the process of assigning patients into various predicted groups. And then I'll introduce algorithmic fairness concepts. These are formal definitions of when a clinical algorithm, in this case, a clinical algorithm that's powering a clinical decision support tool, is fair or not. And I'll try to explain these technical definitions in a way that makes sense. Monica is then going to interpret what I've said in the context of a health equity lens and the history of structural inequity in this country and what that history and the present day structural inequity that our patients face means for which one of these decisions or these algorithmic fairness concepts might be appropriate. And finally, Valerie's going to do the same thing with respect to anti-discrimination law and new federal regulations about AI in healthcare. So hopefully that sounds good. All right. My disclosures are that a lot of my work is funded by both the National Institutes of Health and the Greenwell Foundation. My objectives are first to review the statistics of clinical decision support tools, specifically the statistics of classification, and I'm going to hopefully reveal to you that there are normative clinical medical ethics embedded in these test thresholds. And there's a role for clinical medical ethics during the design of these algorithms and in very specific technical details of when they're turned on and when they fire. And then after we have that, we're going to be able to understand the non-discrimination criteria, the classic 3 non-discrimination criteria for clinical algorithms. But unfortunately, you can't get to the part 2 until we go over part 1. A lot of this material that I'm going to present comes from this really nice book called Fairness in Machine Learning. It's a little technical, but pretty approachable. And then John Harrington from the University of Rochester, who has thought a lot about this and inspired me to dive deeper. Okay. So this is an overview of what a clinical decision support tool does. It takes patient data, usually automatically extracted from the electronic healthcare record, increasingly so with integration of AI tools directly into the EHR, puts it into a black box, and the nice thing is you guys don't need to know what's going on in there and how it's generating the prediction, which is the y-hat. The black box is the amazing AI classifier that's using that information in hopefully a way that we can explain afterwards. But what it's trying to do is predict the patient's outcome, which in this case would be, will this patient be alive or dead in 90 days? That's what y-hat means here. It's a guess that the AI classifier predicts. Based on that guess, either a treatment is triggered or not. The treatment in the example I'm going to present and anchor this discussion around is triggering a goals of care conversation from a palliative physician for a patient based on a prediction of death. All right, so we're going to walk through this process one by one. The first part, as I mentioned, is this classification task, taking the patient's data and turning it into a prediction. This is one of the first big AI breakthroughs in computer vision, where a classifier took these handwritten digit images. This is called the MNIST data set. It's like if you take a machine learning class, this is one of the first things you're asked to solve is this problem, and you fit a convolutional neural network and you train it, and then it can correctly classify all these digits. Here the X is this picture. It's 28 by 28. Of pixels. Each pixel has a position attribute and a color attribute. And the label, there's actually 10 possible labels, 0 through 9 here. So in some ways, it seems like there's a bigger space of potential things numbers could be. And what the black box is going to predict is a guess of what the digit is that was written. And here is the classic, I'm giving a talk on AI, I'm going to throw up a picture of a complicated diagram that's, in the inner workings of the algorithm. But the nice thing is you don't need to know anything about the way this image is being processed by each layer of the convolutional neural network, about the pooling, the convolutional, box size, and all those details. It turns out not to be relevant, but what's critical is to understand is that this is just that image, 28 by 28, going into this black box, and it's spitting out a guess between 0 and 9. And turns out this is a solved problem. So any handwritten digit you can write, the current state-of-the-art foundational models, ChatGPT could do this, take a picture of a digit you've written, it will correctly classify it almost every time. And the times it doesn't correctly classify it, you probably wrote it in such a crazy way, the information wasn't really there, right? So a perfect classifier like this has no false positives or no false negatives. It never misclassifies an observation. So this is a simple version where, let's say there are only zeros and ones in the data set. Every digit that's predicted to be a 1 is with 100% probability, and every digit that's predicted to be a 0 is with 100% probability. This is a solved problem. And this is what the goal of most AI engineers is to perfectly solve the classification task. There are theoretical limits to how well you can do this, but essentially that every time you make a prediction, you're correct. But remember, we're predicting when a patient's going to die. So just imagine how creepy that would be if it could do this perfectly. So spoiler alert, we're not going to be able to achieve that. Here's a Serious Illinois Risk Index AI classifier developed by the University of Pittsburgh. Lots of health systems have these now. EHR embedded tool, it takes the patient's data from the electronic healthcare record and predicts whether they're going to die or not in the next 90 days. What that is used to trigger, the treatment here, is a nudge in the electronic healthcare record to go talk to the patient about their goals and values and have a goals of care conversation. After they turn this on, in the Pitt Health System, the percentage of patients with goals of care conversations went significantly up in this high arm, the arm of the people who had the nudge triggered by the classifier. So to put this onto our conceptual map of a clinical decision support tool, here the clinical decision being supported is when to talk to your patient about their goals of care. The patient data is features from the electronic healthcare record. They picked 390 variables that they extracted. Goes into a black box, turns out to be a gradient boosted machine decision tree based classifier, but that's sort of irrelevant. And it spits out a prediction of will this patient be alive or dead at 90 days? If the classifier predicts the patient will die, or we're going to classify them as dying, then the clinician is nudged to go talk to the patient about their goals. If they're predicted to survive, they're not. All make sense? And the concept at the end of the diagram here is the treatment threshold, which is the threshold of the probability of death at which you trigger the action. And we'll talk about that in a little bit more great detail. So another slide to hammer this home. X here is an 85-year-old man with advanced lung cancer admitted for pneumonia, represented by 390 variables. Goes into the black box, and we have a prediction about whether that patient will be alive or dead the next day, a probability between 0 and 1. Now, the fundamental problem that we face us and why this ends up being an ethical problem is that people are not black and white pictures. So the picture on the left is clearly a 1. It's a little slanted, but all of our brains can classify that as a 1 perfectly, and so can an AI classifier. But just looking at that patient, we can't classify his probability of being alive or dead within 90 days perfectly, and certainly can't do that from the data available in the electronic healthcare record. So what you get is something like this. The white boxes are patients who ended up surviving. The black box is patients who ended up dying. And we can see that there's a distribution of risk here spit out by the classifier. There's a lot of patients who have a 25% probability of dying. So that means 1 in 4 will die, the other 3 will survive, only up until we finally get up to the highest risk bin where almost everyone's dying. But there's a lot of patients who are not perfectly classified. We're going to make mistakes. We're going to classify some patients as dying who end up living, and vice versa. And I'll walk through this one by one. So it turns out we're going to have to draw a line called the treatment threshold based on the probability of death and decide who's going to get this goals of care nudge or not. And we're going to make mistakes with drawing that line. So the first place you might think to start about where to draw this line about who to classify is at 50%. Makes sense. If the probability of death is more than 50%, we classify the patient as dying, trigger the goals of care nudge. And if the probability is less than 0.5, we don't. And so what I've done here is put colors on this plot to hopefully make it clear. All the patients who are in the white boxes are true negatives. So these are patients who don't die and were correctly classified by the AI algorithm as not dying. The blue bars here are patients who ended up passing away within 90 days, but the machine thought they were going to survive on this current threshold of 50%. Once we cross 50%, now we're labeling everybody as dying and triggering the goals of care conversation. And so we're going to make false positive mistakes. The false positive mistakes are in red. These are patients who were classified by the machine as being high risk for death, but end up not dying. Make sense? So what I'm going to end up arguing is that where we set this line is not up to the AI engineer. It's up to you, the clinical medical ethicist, advising this process. This is fundamentally a normative choice that does not have anything to do with with what's going on in the black box of the classifier. And well, we'll get there, I promise. All right, so this is an imperfect, it's projecting a little weird, but I think all the colors are there, fortunately. So we have an imperfect clinical decision support tool. The classifier is going to make mistakes. It's going to make 2 different types of mistakes. It's going to make false negative mistakes. That's when it misses somebody's who's going to die. And it's going to make false positive mistakes where it classifies somebody as predicted to die who doesn't die. So here's that in words. The false negative here is a missed opportunity to talk to a patient about their goals of care who are ultimately going to die. And the false positive is triggering an unnecessary, in quotes, goals of care conversation for somebody who will live. I think already in the room, you may be thinking, well, the blue mistakes, the false negatives, seem a lot worse than the red mistakes, the false positives, right? And that normative analysis ends up being key for deciding where we're going to set the decision threshold. So this is an example to further explain this. Let's imagine that this man that from our previous example has a 60% risk of death in the next 90 days. We've set our threshold at 0.5, so he's classified as high risk for death, likely to die. So we trigger the goals of care consult, right? What about this patient? She's 70. She's early stage lung cancer. She's also admitted for pneumonia, but she's not on oxygen. Turns out her risk of death is 10% in the next 90 days, but we've set our threshold at 50%. So there's no nudge to the clinician taking care of her, and she does not receive the treatment, in this case, a goals of care conversation. And so let's say the patient on the left, the woman dies despite 1 in 10 chance, right? It's not, it happens. She's one of those blue boxes, and she has been a false negative. We've missed the chance to talk to this patient about her goals, and she's died. So the machine has made a mistake, a more costly mistake than talking to the gentleman on the right who ends up to be a false positive. He didn't die, even though he had a 60% chance of dying. He got lucky, the 40% was right. And we talked to him, but it turned out it wasn't necessary because he wasn't going to die. So I hope what is already obvious is that we much rather make the red mistake than the blue mistake, right? And that what type of mistake we're going to prioritize with the algorithm is up to ethical analysis, not computer science. And people designing these algorithms know this, right? They know that they sense there's this normative choice. And so this is from the supplement of the Siri thing. And they say things like, if limiting the number of false positives was of paramount interest. And what the data scientist is saying is like, I need somebody to tell me what the values are here. I don't know what the values are, right? And what they're really saying is like, and we have to get in there with our clinical medical ethics skills and translate to them what a false positive is, what's the cost of a false positive, and what's the cost of a false negative, and tell them, a false negative here is way worse. We need to move this threshold to minimize false negatives. And just to show you what it looks like when you start moving the threshold around, here's that higher threshold. If limiting false positives was of paramount interest, right? So now we move the threshold up. So you got to have a really high risk of death before we nudge the clinician. Well, then see what happened to the blue bars. A lot more missed opportunities to have these conversations with patients. Conversely, if we drop the threshold, we decrease the number of missed opportunities to talk to patients about their goals at the expense of having more, quote unquote, unnecessary conversations with patients who end up surviving. So there's a trade-off here. It's a normative one, and it requires values. And the Siri people recognize this. They set the threshold at 30%. So implicit in that threshold setting is up to in this case, the health system, what matters more. And you can actually use formal decision analysis. This is a form of decision curve analysis, clinical utility analysis, to quantify what this means. There's supposed to be a scale that's tilted towards missed goals of care, but I think you get the point that what this threshold means is that missing a conversation with a patient who dies is over twice as bad as failing to have or having an unnecessary conversation with somebody who lives. But you could argue that that's actually like maybe not even too low, right? I think it's probably 10 times as bad to miss this opportunity to talk to somebody about their goals who ends up dying than to have a conversation with somebody who is a pretty high risk of death, but doesn't end up dying. There's the cost, that red cost is actually pretty small. So, when they turn this algorithm on, the false negative rate ends up 27%. So they're missing 1 in 4 patients who die under their current operating threshold, which I think means that this algorithm is not operating at the space that is providing the maximum utility or benefit to patients. So there's this explicit process of mapping ethical values to this threshold that requires clinical medical ethicists who can integrate clinical details and the ethical principles and help guide the people setting up these clinical decision support tools. So with that background, I'll spend a couple minutes before I kick it over to Monica setting up what the non-discrimination criteria are now, right? So we've just been speaking in general across the entire population about how important it is to set the threshold at the right point to balance false positives and false negatives according to the ethical weight of either of those mistakes. But what if the algorithm is making more mistakes for one marginalized group compared to the in-groups? And the way machine learning people think about this is they describe these as sensitive patient attributes: gender, race, ethnicity, place of birth, disability, religion, that are explicitly protected under US law, groups that have been marginalized and subjected to structural violence over time. And just for the purposes of the criteria I'm going to set up, I'm in no way going to address intersectionality, but instead just treat this sort of as a binary in a marginalized group or not, which is overly simplistic. But there are three mutually distinct and mutually exclusive non-discrimination criterion. There's mathematical proofs of the mutually exclusive part called the impossibility theorem that I'm going to walk through one by one over the next 5 minutes. That all try to impose certain technical restrictions on the algorithm's performance that would determine whether it's fair or not. The first one is independence, or demographic or decision parity. This is that the algorithm needs to trigger the treatment at the same rate for all groups. So for Siri, that would be operationalized as a goals of care conversation nudge occurs at the same frequency for white patients and black patients. So in practice, this algorithm, Siri algorithm, violated independence. It was more likely to fire on white patients compared to black patients. So that's independence. In some ways, it's the simplest algorithmic fairness criterion, that whatever you're allocating, the treatment in this case, these conversations, occurs at the same frequency across groups. But there's some problems with independence. First is that if the non-sensitive features and the sensitive feature are very correlated, the model becomes less accurate. In this case, what if white patients are older and have a greater burden of, they're unlikely to have a greater burden of chronic diseases, but if they're older, they're more likely to die. So being white is correlated with being old, and then if you try to force the algorithm to fire at the same rate for white and black patients, you'll level it down and make it worse for both groups. So that's a problem, that if you're forcing independence, you may limit the performance of your algorithm. There's this idea of an 80% rule, which is there can be some inequality of predictions within a small threshold. And then you can imagine other scenarios where the marginalized group is at higher risk of death, and you're allocating a treatment that may lower that risk. And if you were forcing independence, you'd be making the marginalized group worse off because they would be less likely to be treated. So that's a classic equal not equals equitable problem. And then the last thing is that if you force this independence criteria, you can normalize and reinforce health inequities. It's kind of an extent forcing the algorithm to perform in a race equal way, and perhaps may normalize and reinforce the baseline differences and forces of structural racism and inequity that have caused one group to be at higher or lower risk of death. So there's a lot of problems with independence. The next criterion is separation, which is what the FDA requires for the performance of tests. So it's important to know if you're trying to get a test approved by the FDA, which is that the false positive rate and the false negative rate are the same. I haven't gone through a receiver operating characteristic curve, but what this is, or I think I showed one earlier, but I didn't explain it. This maps out the x-axis here is the false positive rate. So this is how often you classify something as having the event that doesn't. And then the y-axis here is the true positive rate. How many times or the sensitivity? How many times are you correctly identifying a person with the event? And what the FDA says is that you have to pick the threshold such that the true positive error rates are equal. And so it's, in other words, it's equally sensitive and specific for each racial or ethnic group. And I think this one also has a lot of issues. You can imagine that it has the same leveling down performance in one group for fairness reasons. And more importantly, it ignores the fact that the threshold should be set by the relative weight of true positives or of false positives and false negatives, like we just spent the first 15, 20 minutes of my talk going over. And if you just pick this threshold so that these error rates are the same, you may be significantly disadvantaging both groups. especially the marginalized one. So I think even though this is what the FDA is insisting on, is a very problematic standard and may actually make marginalized groups worse off. And then the last criterion, which I think makes more sense, makes a lot of sense to me, is that the algorithm the score means the same thing. So that the score value on the x-axis here, it's the prediction, is actually equal to the true rate of the outcome. So if the score says you have 50% chance of having the event, you do have a 50% chance of having the event. Doesn't matter if you're, in this case, if you're white, black, or Asian. So that another statistical way to describe this is that the score is well calibrated for each racial and ethnic group. And the nice thing about this is it works for any treatment threshold. So we pick our treatment threshold at 10% because we really don't want to miss people who die. And it's well calibrated at that one, you're in business. In crisis standards of care, the sequential organ failure assessment score, which is unfortunately still the main triage score that would be used in a crisis, is very miscalibrated and for black patients and violates the sufficiency criteria. The reason it does that is it's like a 25-year-old score. It was made up in the 90s. It's not based on a regression. This would be easy to fix. This is not there's no good reason that this is occurring. It's just lazy statistics. And not or refusal to update the score, but we're working on that. So, with that, I want to turn over to my other panelists for their perspective on these ideas. And I think hopefully what this talk was helpful in illuminating is that there are these subtle technical decisions that you have to make when you're designing and turning on a clinical decision support tool that to make it effective for all patients that rely on a lot of clinical knowledge and a lot of ethics knowledge. And these criteria are useful perhaps diagnostically to understand the greater context in which these tools are operating. And it doesn't necessarily mean that there's going to be one perfect right answer for every situation. And I think I just said most of these words already, but I think, this, and hopefully all these points at this point are clear. And I think I've already put in my plug for calibration parity or sufficiency as perhaps the best fairness standard for most healthcare allocation algorithms. All right, well, thank you for your attention, and let's turn the slides over to Monica. I think we'll just hold questions till the end and do a panel discussion. So thank you so much.
Did you update that? Will is very tall.
Did I update that?
Yeah, you definitely
This is the same one.
Oh, it felt wrong.
What?
Maybe the second time around.
I just said
got it
different
more.
words, maybe. Something's first.
Great, thank you. I've never had to do this before. Okay, is this good? All right. Wait, and now I can't even see what I'm doing. Okay. Great to be here. Thank you all for coming downstairs and joining us. Will, that was great. We did this last month at a different conference, and you changed your slides a little bit. Well, anyway, last time was great too. So I'm going to talk a little bit about structural inequity, particularly related to race, and how we can think about clinical algorithms, just one of the ways in which they may not be fair for all populations if we're not really sort of putting a lot of thought into them, which Will has talked about from the mathematical perspective, and I'm going to try and just sort of take a step back and think about them from a different kind of perspective. All right. So this in itself is a whole lecture. So as opposed to arguing with y'all or like having a conversation, I'm just going to say that race is a social construct, that while there are biological and genetic differences, we really, if we want to think about ancestry, we want to think about genetics as opposed to saying that the skin color is the primary way that we're going to find differences between populations. And if you actually really think about it, if you had landed here from Mars, you would look at the size of the African continent and think about the diversity of the people on that continent, from South Africa all the way up to Northern Africa, and think, wow, that's a lot of phenotypic diversity. And think about the people who came from Africa to the United States and the fact that we used the one-drop rule to sort of maximize slave ownership, so that if you had one drop of black blood, you were considered black and eligible for slavery. So then think about the phenotypic diversity within black Americans in this country and the genetic diversity of black Americans in this country. And so it just seems ridiculous, honestly, to think that all black people in this country or all black people in the continent of Africa would be so genetically similar to each other that were that dissimilar to white people, right? So just common sense. But then when you look at genetics, you see that there's more intragroup heterogeneity than there is intergroup heterogeneity. And so again, if we want to be more precise around racial differences, we want to think about genetic differences. So, but I will say that racism, exposure to oppression because of the color of our skin, does cause biological changes. We can induce those same biological changes if we decided that nobody liked, people who had a certain foot size and made them all live in a bad part of town with no resources and didn't give them jobs and spit on them every time, those kinds of physiological pressures that, the fight or flight and the lack of resources and exposure to toxins, those are things that are harmful to your health and can cause harmful genetic imprinting on you. We can do that to anybody, but currently we do that most commonly to people who have dark-colored skin. So that causes changes, but it's not this long lineage going back, because of where we're coming from for the most part. So I do want to make that distinction, that we do find racial disparities, most of them having to do with current conditions of racism. And so race is a marker of exposure to racism, as opposed to somehow this pigment in my skin is a marker of deeper things. I have a friend who's on the transplant service right now, and she is Indian. And someone asked her, who's trying to get a free transplant, if they were going to get an Indian organ or if their organ was going to be white like them, particularly American like them. And I asked her if she kicked him out the hospital. She didn't. She's very kind. Do you want an organ at all, sir? So anyway, we have a lot of, it's too close to the election. So we have a lot of structural inequities in our society. And what that means is that there are policies, laws, procedures, and norms that differentially limit the access to goods, services, and opportunity. We increase the access to harms, toxins, and things like that. So more of the good stuff, less of the bad stuff if you, are on the good side of the coin. compared to the bad side of the coin. And that all of those are not randomly sort of distributed in our society, but they occur along these fault lines of social identity, those identities that are marginalized. And so we have lots of ways in which we can define ourselves in this country. The one that has the strongest signal is race, and for lots of reasons, which I won't go into. But in other countries, it may be religion or ethnic identity. And so there's just but there are lots of ways in which we can think about that. And so if we think structural inequity based on race, that's what we call structural racism. And I'm talking about this so that we can understand when we put race into these models, we can try and figure out what work we're asking that variable to do for us. What are we trying to really capture when we do that? So one of the things so I'm a primary care physician, and I see my bread and butter is, diabetes, hypertension, asthma, many of the things that are listed here. And we know that structural inequities around residential segregation, community violence, food insecurity, other kinds of limitations in the built-in social environment have been associated, usually through observational studies, cross-sectional studies, but some longitudinal studies with poor outcomes in health. And so that's not a good thing. So there's a woman named Kamara Jones who's been a pioneer in this work, and her framework for thinking about racism really has to do with three different levels. And I'm a huge fangirl of her. And so I took this picture with her a couple of years ago, but the very first time I saw her, she was giving a talk. And I came up to her afterwards and I threw myself around her, started crying, and I'm just thankful she didn't call the police. She's like, who is this crazy person? So anyway, every time I have a slide of her work, I put my selfie in her on the slide. So she first talks about institutional racism, which a lot of people use interchangeably for structural racism. And there's some nuanced differences, but for our intents and purposes today, we'll say that they're the same. So again, the differential access to goods, services, opportunity, and harm based on race. And so if we're thinking about what that might measure, we can think about residential segregation, racialized residential segregation. So in a lot of studies, we see people use the area deprivation index, the social vulnerability index, all these different measures of neighborhood vulnerability that we know has been associated with basically every poor outcome. We used it a lot during the COVID pandemic. It's been associated with overall mortality, increased morbidity around HIV, cardiovascular disease, diabetes, morbidity and mortality. Just almost name a disease and it's going to be associated with that because of all of the things that happened around not just forced residential segregation, but the disinvestment that went with that in those communities and the extraction of resources. So when we think about that, those are usually measuring, income in those communities, access to health care, things like that. The other that people mainly think about when they think about racism is interpersonal discrimination or interpersonal racism. And so interpersonal racism is both prejudice, sort of the differential assumptions about people based on race, and then discrimination, the differential actions towards people based on their race. And so this is not the exposures to life opportunities or the lack of exposures to life opportunities, but it's that the things that, and it's a bidirectional relationship, but how people are treated. And if you're in a healthcare system, will people be offered healthcare, resources? And so we think a lot about, clinician bias, whether or not that's implicit bias or explicit bias. And so there are, lots of ways to sort of measure perceptions of discrimination, and people's implicit biases around various kinds of social identities and things like obesity and other kinds of patient characteristics. But this is a different kind of thing because the chronic perceptions of discrimination are one of the major pathophysiological mechanisms that chronic stress that triggers autonomic dysregulation, the cortisol pathways, all of these other things, that internal like hotness that you get, that we think based on, cortisol and CRP and some of the other interleukins is related to a lot of the chronic diseases around cancer, cardiovascular disease, et cetera. So not only are people, not having access to hospitals, getting exposed to carcinogens, not having educational opportunities where they can get a job with health insurance, et cetera, their bodies are also physically changing because of the stress of being discriminated against. And so both are putting them at increased risk for chronic diseases through separate pathways. And there are actually lots of pathways. And then there's the internalized racism. And I want to be clear that this is not everyone's internal thoughts about racism. This is the, for marginalized groups, and in this case, for marginalized groups based on race, their acceptance about themselves of the normative standards that Black and brown people are inferior. And so how they feel about their own ability and their intrinsic worth that may show up as learned helplessness, hopelessness, loss of confidence, the fact that I might not feel as able to manage my chronic diseases, my expectations for life, my expectations that I'm going to live a long and healthy life, how I value my life, how I might value your life, someone who looks like me. And so what we're seeing sometimes in communities around community violence and self-harm and other harm and managing chronic diseases, a lot of times is a reflection of internalized racism. And we see that not just in this country, but we see that whenever we go around the world and look at oppressed populations. This kind of framework of how people are living in systems, how they are surviving, how they're interacting with each other and with oppressive groups. These are the patterns that we see. We have somehow believed that this is inherently who Black people are because this is the group that we know the most. But this is not a Black thing. This is an oppressed people thing. And if we can take the time to step back away from ourselves and be anthropologists and sort of global citizens, we'll have a better understanding that these are mechanisms of oppression that are playing out in our country, and that we would do better to sort of learn about them, to understand how not only to address the health of the population, but that population's health is affecting everyone's health. And so these are some of the mechanisms through which racism can affect health. So getting back to this idea of these algorithms, is it better to be race neutral or race conscious? And what are the various mechanisms that Will was talking about to get there? And so I would say that we want to be race conscious and think about, the impact. And so these are three areas that we've seen a lot of controversy around: the EGFR, the lung spirometry, and vaginal births after cesarean section, where we have taken, I say we like it's, but we as a medical profession have taken race out of the algorithm because the science has not been there for why it was put there in the first place. And we see that with the example of taking race out of GFR, we have been able to more quickly come to a diagnosis of renal failure amongst African American patients, which has led to them being eligible for kidney transplants earlier. And there are already sort of a lot of biases in who is offered a transplant, but at least they can be eligible for transplants earlier. And just last year, the Oregon Procurement and Transplant Network instituted a new policy that said for people who've been on the wait list for a long time because they were on dialysis, but should have been offered a kidney earlier, they get additional time served. So thinking about the independence, the separation, the sufficiency that Will was talking about, all of these are really important because we have to think about what, again, what is race being a proxy for? Is it saying that African Americans, other marginalized groups have a higher disease prevalence? And so therefore, the models aren't going to be the same? Is it saying that, like we found with that SOFA study, that it's not going to predict as accurately because Black people are more likely to have chronic kidney disease, and chronic kidney disease does not show up the same way in an acute hospitalized setting as acute kidney disease for a white person. So their mortality is going to be different. They're going to do better. And so, but they're more likely to have chronic kidney disease because they're more likely to have lots of, chronic problems. And so, or is it that people are going to be less likely because of bias to be offered a treatment in the first place? Were they, misdiagnosed? Like what work is causing the disparity in the first place? Is it that, that there are, how are we determining what are all the factors that are going into the equation? And then how does race interact with those factors? And what part of that is important for equity? And so we have to sort of think about that when we're trying to decide whether race should be in there or race should not be in there. Because there have been some studies that have shown that taking race out of the equation actually leads to exacerbated disparities. And so the better question is, how can we try to make sure that we have equitable outcomes? And so people have been thinking about this and writing about this and trying to find some guiding principles. This is a paper written by a lot of people, including Marshall Chen, who's one of our associate directors here. And this is a figure that no one can read, but it talks about sort of authentically engaging with the community and having sort of this process for figuring out if the data is relevant. But a lot of it is that you want to make sure that the data that's used for building and testing the systems is at least accurate and reflective of the population. Do you have enough people in there that reflect the population it's going to be serving? And is the disease prevalence of Black and brown people in that population the same as it is in real life? Are these healthier people, less healthy? There's the same, are they coming from the same sort of areas of neighborhood vulnerability or not? Like, who are you testing this model on? All of those things. And then this is another one, sort of more things you can't see, but another way of sort of saying these are the specific questions that we should be asking yourself when developing a model. And so one of the things that I think it's important for us to sort of consider as we think about race and the implications for discrimination, and this sort of gets to what Valerie's going to be talking about, is what it meant for us in 1964 and what it means for us in 2024. And so when the Civil Rights Act was passed in 1964, it made discrimination illegal based on race, but also on a number of other social identities, and then sort of later brought in sexual orientation and gender identity. And it was because at the time, there were all of these, what I call what Black people can't have laws. Black people can't have equal education. There's all this separate but unequal. So Black people couldn't be around town when the lights went down, these sundown laws. Otherwise, you could shoot Black people, or you could arrest them or lynch them or whatever. Black people couldn't drink from the same water fountain. You couldn't have the same, whatever. And so the idea was to try and erase laws that specifically said things around race, because all of those laws were discriminatory. So the idea of having a colorblind society was really sort of a short-term utilitarian strategy. It wasn't that that is the end goal. But right now we want to be able to not judge people based on race, because doing so is harming Black people. Now, what happened was we took those off the law books, but you see that we haven't really changed. So if we think about our school systems, they're still very segregated. We have very few integrated schools. So instead of Black schools and white schools, we have public schools and private schools. Our public schools are mainly, Black and brown, and our private schools are mainly white, or have most of the majority of white kids. And we have found all of these workarounds to keep all of our systems of segregation mainly intact, but doing so without actually explicitly saying so in the law. But so structural racism is still here. We've just been more clever about it. And just as we've seen with all of the laws around voter suppression, we no longer say Black people can't vote, but we just put these things into place that make it very specific to marginalize, that disproportionately affect Black people and marginalized people around voting access, or Native Americans. And so now, if you want to have equity around race and address racism, then you have to be able to say, I want to specifically have these things that are countermeasures around racism. You have to be able to say race. And within AI, they've been very specific in saying that these cannot exacerbate discrimination or disparities for populations that have been historically harmed. But what we've seen nationally is that the laws around discrimination have been used against marginalized groups. So saying that, okay, we're not allowed to have race, as a factor at all in how we see school admissions or anything else. That is sort of getting to my bottom line, is that you can't ignore race until there's no racism. So what we're doing is saying we're pretending as though all the structural racism has gone away, and we are starting to ignore race as a variable, despite the fact that we know that structural racism still exists. And so that's sort of the backdrop in which our society is functioning, and which, as we sort of roll out these clinical algorithms and we're trying to make sure that they're equitable, we have to still understand that racism is still functioning. And we have to think about the ways in which we want to make sure that everyone is still having an equitable chance, and that those who have historically and are currently most harmed have an even playing field. Most of you have probably seen this, and it's a way of thinking about equity, and that equity is not the same as equality, where everyone gets the same equal gadget or widget or bicycle, despite whether or not that's actually what you need. Equity is trying to give everyone the resources that they need to make it to the finish line on time. And so we think about fairness not just to each an equal share, but to each according to need. And so we really want to be thinking about that definition of fairness and justice as we think about advancing racial equity with clinical algorithms. And with that, I will turn it over to Valerie.
Okay. So when Will invited me to join this panel, he asked me to speak to sort of the legal landscape of incorporating questions about race, the factors that would presumably mitigate discrimination into clinical algorithms in ways that either, well, hopefully don't run afoul of the law. So what I'm doing here is a few things. The first is I'm going to give a little background about what the law is, talk about addressing discriminatory tools, then thinking about using CDS tools to mitigate discrimination, and then finally looking a little bit to what happens if we were to ignore those anti-discrimination laws when implementing CDS tools with the intent of mitigating historic inequities. So a little bit about existing law. So the key law that applies to non-discrimination in healthcare and in programs and activities is Section 1557 of the Affordable Care Act. So federal law, as Monica just mentioned, has prohibited race discrimination in healthcare since 1964 with the passage of Title VI of the Civil Rights Act. Now this Affordable Care Act provision incorporates protections from Title VI as well as Title IX of the Educational Amendments of 1972, Section 504 of the Rehabilitation Act of 1973, and the Age Discrimination Act of 1975. So Section 1557 thus prohibits discrimination by health programs based on sex, race, color, national origin, age, and disability. So Section 1557 then extends those non-discrimination protections to people at the intersection of multiple identities as well. And it applies, again, to health programs or activities that receive Health and Human Services funding, either directly or indirectly, such as providers and insurers. So in recent years, policymakers have become more concerned with the possibility that clinical algorithms and these tools will be intentionally or unintentionally used for discriminatory purposes. And so they've recognized that CDS tools have historically produced discriminatory results due to inaccurate scientific theory or using inappropriate proxies for health, often inappropriately adjusting results based on reporting results and unreported results and ethnicity. So race or ethnicity, sorry. So the White House, in this most recent term, expressed support for the ethical use of AI in automated systems generally, raising specific concerns about algorithmic discrimination. So in 2022, the White House published its blueprint for an AI Bill of Rights. It's not binding, it's an advisory piece, but it does indicate the direction that the administration was going in, or perhaps maybe is still going in the next couple months. It cautions that algorithmic discrimination on the basis of protected class may violate legal protections, and it really focuses on proactive equity assessments as part of system design and the use of representative data and protection against proxies for demographic features. And then in October of 2023, President Biden issued, there we go, an executive order on the use of artificial intelligence, stating that, quote, AI policies must be consistent with my administration's dedication to advancing equity and civil rights. And it continued, my administration will seek to ensure that AI complies with all federal laws and to promote robust technical evaluations, careful oversight, engagement with affected communities, and rigorous regulation. In August then of 2022, HHS proposed to extend Section 1557, the ACA's anti-discrimination requirements that I just discussed, to patient care decision tools specifically. So responding to that executive order, the Office of Civil Rights, OCR, at the Department of Health and Human Services promulgated a final rule just a few months ago. So in 2024, after a couple years of required notice and comment rulemaking. And so the final rule, 45 CFR 92.210, expanded the ACA to cover, quote, patient care decision tools, is how they refer to them. So if CDS tools end up being discriminatory in effect, those who use them or develop them are subject to the same anti-discrimination laws as those who have historically been subject to them when discriminating against disadvantaged groups in healthcare generally. So Section 92.210 expressly prohibits a covered entity from discriminating on the basis of race, color, national origin, sex, age, or disability in its health programs or activities through the use of CDS tools. So this section specifically obligates the covered entity to do two things. The first is that it must make reasonable efforts to identify uses of, quote, patient care decision support tools in its health programs or activities that employ input variables or factors that measure race, color, national origin, sex, age, or disability on an ongoing basis. And the rule requires that for each patient CDS tool, that the users or the creators make reasonable efforts to mitigate the risk of discrimination resulting from the tool's use in its health programs or activities. However, in this rule, HHS did not define illegal algorithmic discrimination, but it provided examples where discrimination concerns arise, including the use of race or ethnicity variables or proxies in patient CDS tools, reliance on prognostic scoring systems that exhibit differential performance by race, scoring, or ethnicity, even when such variables are not included directly, and COVID-19 crisis standards of care that may discriminate against older individuals or those with disabilities, as we saw some of those, the SOFA scores and the other algorithms sort of ending up sort of having that effect. But HHS does not explicitly say then what types of algorithms are most likely to actually run afoul of this rule, and we've yet to see any related litigation that sheds light on that. The rule, importantly, particularly in the context of today's discussion, does not focus on what to do when CDS are crafted to intentionally avoid or mitigate discrimination, or to counteract existing biases in human decision-making. So if CDS tools account for race or other factors at all, then they're probably unlikely to run afoul of 1557. But what happens when these tools are intentionally used to remedy inherent bias in the healthcare system, as we're talking about here? So, for one thing we know is that Section 92.210 does not prohibit the use of protected characteristics or as inputs to the algorithms. Rather, it cites age as an example. The OCR, the Office of Civil Rights, explains that such use is acceptable if considering the characteristic is clinically indicated or otherwise conforms to best practices. And in responding to those 2 years of notice and comment that led up to the promulgation of that final rule, OCR acknowledged that some bases protected by Section 1557, such as age, are prevalent in CDS tools and may not actually require extensive mitigation efforts if use of the variable that, in the tool does not result in discrimination. For example, by showing that age is clinically indicated as a measure in that particular tool and or aligns with evidence-based clinical best practices. However, OCR did note that some input variables may generate greater scrutiny, might require more scrutiny, such as race. So historically, individual race classifications are treated very differently from policies that are motivated by or consider race more generally. So Title VI of the Civil Rights Act prohibits discrimination against individuals because of their individual race, but not race-conscious decisions more generally. So policies that treat individuals differently on the basis of race, even in order to potentially address disparities, must satisfy what's known as strict scrutiny, a really high level of scrutiny. So strict scrutiny requires, at a minimum, that the use of the classification be narrowly tailored to realize the state's compelling interest in its rule, in its policy. So in other words, to justify the use of race, one must be able to establish a compelling interest using a consensus of objective medical evidence and be able to show that the use of the race distinction is narrowly tailored to support the stated compelling interest. So, for example, courts that would likely reject a policy that allocated scarce treatments on the basis of individual patients' race, regardless of whether those policies aim to address racial health disparities or promote overall population health. However, a policy that considers race without classifying anyone by, considers race without actually classifying any individual by race, does not have to satisfy strict scrutiny. So absent an individual race classification, strict scrutiny is only then triggered if some additional condition is met. Such conditions include, for example, an intended adverse impact on a racial group or disparate treatment, or the use of a classification that is a pretext or a proxy for racial discrimination. Strict scrutiny also applies if a policy aims at racial balancing or it is motivated exclusively or predominantly by a racial purpose. But recent Supreme Court jurisprudence that Monica alluded to in her talk indicates court suspicions regarding the use of race to mitigate inequities. So this past June, in a case called Students for Fair Admissions versus President and Fellows of Harvard College, or shorthand is SFFA, the Supreme Court held that affirmative action programs designed to comply with past precedent to withstand strict scrutiny were in fact illegal. So the case addressed whether race-conscious admissions at Harvard University and the University of North Carolina violated Title VI of the Civil Rights Act or the Equal Protections Clause of the 14th Amendment of the U.S. Constitution. The schools had been using race as a plus factor in the context of a, quote, individualized, holistic review of each applicant's file. So all of this seeming to follow completely along with sort of the expected requirements of how we can use race in thinking, individualized race in making these sorts of determinations. And it did so arguing that their systems were narrowly tailored to serve a compelling state interest in obtaining the educational benefits of diversity. But the court said no. The court said this violated anti-discrimination rules, and in so holding, the courts emphasized the goal of colorblindness or race neutrality. So SFA, while only really discussing decisions to accept students or reject students at the university level, despite that, is really the harbinger of future legal opinions where efforts to ameliorate historical structural inequities will be stymied under the justification that doing so will discriminate against others, and in particular, against groups that have not suffered from historic inequities. It's posited that perhaps health programs may fare better than educational ones with respect to SFFA's emphasis on that the interest justifying racial classifications must be sufficiently coherent for the purposes of strict scrutiny and capable of being, quote, subject to meaningful judicial review, but that really remains to be seen. And honestly, if you're asking about what I predict, given where I have seen the courts going lately, I would not believe that SFFA is the last we're going to hear about this. Okay, So finally, what happens then? What are the implications then for healthcare systems that ignore these anti-discrimination laws when they're implementing CDS tools, presumably with the goal of actually mitigating historic inequities? So violations can expose healthcare professionals to federal enforcement actions, as well as funding loss, including termination from Medicare or various fines. So starting in May of 2025, OCR will address potential violations of this new rule through complaint-driven investigations and compliance reviews. The OCR typically enforces Section 1557 through corrective action plans. Individuals can also seek to enforce, individuals can seek to enforce Section 1557 through their own private lawsuits. And however, courts disagree about whether private actors can sue for disparate impact or practices that are technically neutral on their face but have discriminatory effects. And that's obviously in contrast to discriminatory treatment cases or disparate treatment cases where the discrimination is intentional. And with that, I will open it up and we can have a conversation about this. Thanks.
Okay. Would you mind passing the microphone around if there are questions? Well, thank you so much, Monica and Valerie, for that, the context, and hopefully we're able to integrate things together. Yeah, I think there's the explicit use of race in an algorithm, and analogous to explicit use of race in university admissions. I think that will be perhaps an area of focus. The initial move, because race was used and still is in many different clinical algorithms. So for assigning cardiovascular risk, for example, in the ACVSD calculator, I wouldn't anticipate that would be necessarily a target for a lawsuit or an enforcement action for this against who, right? The legal side of that would be interesting. But I think what's different is that we've made a move to remove race as an explicit algorithm or a specific variable in the algorithms, often for somewhat unclear, I think, in some of the circumstances, equity objectives. And I wonder how things will be reassessed over the next several years as more and more of these tools get more and more sophisticated and turned on in the healthcare record. So that's just my initial observations. But let's take some questions.
Thank you to all the speakers. I was going to ask the panel about, during the first talk you mentioned the risk threshold as being, we need to see that as explicitly within the domain of clinical ethics, right? Versus machine learning, which is not going to answer the question of where the appropriate risk threshold is. And so my question is, in light of the last two speakers, and in an effort to build more equity, would it be legitimate to reintroduce race that we have perhaps wrongly tried to eliminate in an effort to achieve race neutrality, perhaps wrongly? Would it be legit to reintroduce that by, for example, crafting treatment thresholds differently for different races?
Yeah, that has been, or one of the issues with separation as a criterion. The second one that this is echoing really badly, but that if you actually want to achieve, sometimes you can't achieve separation mathematically at all unless you set different thresholds. Like I showed a curve with time when the curves cross, but sometimes you need to you actually have to pick different thresholds for different groups, but then that's equivalent to using someone's racial identity explicitly in the algorithm, right? Because you may be not using it to calculate their predicted probability of the event, but you're using it to assign the treatment or not. And I feel like that sort of decision-making is actually more likely to come under legal scrutiny and become more obvious. It's like, if your predicted probability of having X disease is 50%, you get treated if you're black, but if you're white, it's 30%. I feel like that's something that will become more obvious, to patients than actually if the predicted probabilities are miscalibrated for black or white patients. Like, that's a little bit harder to diagnose. But yeah, no, that's something that's been explicitly discussed.
Thank you. I learned a lot. Let's see if I need to turn it down. I'll just hold it further out. Thank you. I've learned a lot. I also am concerned about the black box and wondering, is there no theory driving what goes into that black box? So for instance, when I think about what I would want in a black box to predict seriousness of illness, I can't imagine why I would want race if I have comorbidities, if I have deprivation index. I don't like the fact that insurance might be thrown in that black box. If I'm
You
really
picked up on all those sensitive attributes that are going in. I didn't explicitly mention that, but yes.
I don't like that.
Yeah.
I think that we're measuring some things multiple times and putting a thumb on the scale. If I wanted to mitigate discrimination, I would want to have a theory-driven black box and then use those variables to measure whether I'm seeing differential outcomes, because we know that racism still exists and that people may have more chronic illnesses, and we know that certain groups in society are more likely to have publicly funded insurance or to be uninsured and whatnot. So is there no theory that's determining this black box?
Well, I guess there's an amazing amount of mathematical theory that underlies ChatGPT and all the AI algorithms that are operating today that allow them to be so accurate in predicting, classifying, the next words that would come out in a sentence, or what those medical images are, or even generating predicted probabilities of death that are very, very well calibrated and highly accurate. So the black box itself is actually sort of brilliantly designed, but you bring up the question of what are you putting into the box in the first place, right? And should there be restrictions on the features that are permissible to be considered in the box? The one thing I'll say is that even if you omit race, for example, from the list of sensitive attributes, if there's enough things you put in that are correlated with race that perhaps have more actual explanatory power than the social construct itself, you can end up achieving the sufficiency threshold, meaning that making the model calibrated for all groups. So to say that again, it ends up not actually mattering if you put in the sensitive attribute or not, if you have enough other variables in the model that you're throwing in that are correlated with the attribute.
We've changed the behavior, though, of the clinical team when we give them a nudge.
Yes.
And sometimes those nudges could result in behaviors that make it more or less likely that they might be encouraged to be DNR, or to think about hospice or other alternatives. So I'm interested in the false positives and false negatives, and whether we're looking at any of these variables to see who those people are and what distinguishes them.
Yeah, no, and that's that's always something you should do regardless when you turn one of these algorithms on, is look at your misses. I guess my point was that the 11% firing rate for white patients and 7% for black, that would probably happen regardless of whether or not you put black and white in the model. Because there are other variables correlated with being white or black that are in the model. And it would recreate that same violation of the independence because the event rates are different in those two groups. So that was what I was trying, my first point was that it ends up, if you have a sufficient number of other features in the model, the choice about whether or not to include race explicitly ends up not mattering. It only matters when you are doing things like setting different thresholds for racial and ethnic groups, or you have a really simple model. And the other thing I think I forgot to sort of frame this around is we should always compare these clinical decision support tools to nothing, right? So that's the important comparison, is having no nudges at all in the electronic healthcare record, right? And in some situations, that may be preferable to turning on the tool, but I think in most of the time, even if the performance is a little unequal, turning the tool on will be better, make the marginalized population better off than not. There are exceptions to that, of course, but I think that's an important thing to remember that I didn't really frame my talk around well. Right.
Well, and I appreciate that. I'm going to push back a little bit on the idea, though, of goals of care, because I actually am uncomfortable that we just target certain people for goals. I want that lady, early stage lung cancer, to begin to have goals of care conversations. And we've got that opportunity when we're talking about, do you have an advanced directive? You know, we begin to have that conversation. We may not go into as much depth with that lady as we would somebody who clearly is looking like they're approaching the end of life. Mm-hmm. But I don't want goals of care conversations to also be, oh, the Grim Reaper is entering my room.
Right. No, and I think that's what I was hopefully express is I think a 30% threshold is way too high. It should be something like 5%, right? Where you would optimally set that. I mean, I don't think it should be firing on, if I get admitted to the hospital for a broken ankle, I hope nobody's coming in with a pulsed form. But, you know, so I think there is a cost to treating everyone with a goals of care nudge. I mean, there are some patients who that's not the best use of the clinician's time. But you're right, like even at a pretty low risk of death, having this conversation is immensely valuable from a medical ethics perspective. So I was hopefully arguing that a 30% threshold is far too high, and it's going to cause far too many false negatives, like you just said.
Thank you.
So I'll just say two things. I'm a primary care doctor, and I, with my Medicare wellness visits, have been having a whole lot of filling out of forms and advanced care planning, because that's the only time I get paid for it. And so what I have found is that there are too many of my patients who, when I'm attending in the hospital, have never had these conversations. I meet them for the first time, and they're on their deathbed and have never thought about it. And so as a primary care physician, I'm trying to do all that on the front end when they're completely healthy, and having a conversation isn't all stressful. But the other thing is that in trying to figure out all these things that, you know, mechanisms by which racism, you know, leads to poor health outcomes, the things that have varying impact, sometimes are hard to predict, you know, and to include. And so I remember there was a study done by one of our medical students, and the churn in our Chicago jails accounted for a lot of the racial disparities within Chicago, because they were happening at the same time that people were protesting around sanctioned state violence for unarmed black men. And so, and we're getting rounded up and put in jail and then released with less than a day, but their masks were taken, they were getting exposed to COVID, and then getting re-released into the community. And so that is a form of structural racism, the over-policing of Black people for protesting against injustices about Black people, all this stuff. But how would you think to put that into a clinical algorithm? Asking about, have you been inordinately arrested last week for protesting George Floyd? But not include race. I mean, there's so many ways in which injustice impacts our lives. And so you're not going to be able to put all those variables into something and make a super accurate prediction, even if you're adjusting for the things that we typically think about.
Right, that pushes back against my previous statement. Like, you don't always have everything measured in the clinical context to get enough variables that are correlated, or the real explanatory variables aren't measured. Effects of interpersonal racism aren't measured. If you think about the cardiovascular risk calculator, that's a good example. Even if you put in where somebody lives in their place-based disadvantage index, I bet there would still be an effect of being Black on your risk of cardiovascular disease because of the different layers of racism that Monica described. And we don't have them a survey or some validated instrument to measure those, or their cortisol levels clinically. We have their age, whether they smoke, their blood pressure, the things that guide statin therapy. So my dream scenario of always having enough variables that are correlated with the sensitive attribute that it's going to be irrelevant isn't actually the clinical context in many, many primary care settings in particular.
And if I can add, thinking about how also, some of these algorithms might be developed for use in one particular circumstance and then used in a different circumstance. And so, I'm thinking about algorithms that are actually, say, developed for law enforcement purposes. There's PDMPs, the prescription drug monitoring programs, that are now used in treatment decisions about whether patients should be prescribed opioids or not for pain relief. And there are some that are AI informed, like there's one Narcs Care, for example, that there's been a lot of scholarship and pushback about. But those include all sorts of factors like prison time, like all sorts of other factors that might not, or repeat requests for opioids, often even requests for one's pets that now, when their pets are prescribed opioids, that are now incorporated into the algorithm and they're reported back, and patients have no idea what's actually being, what goes into that black box and what's being fed into that black box, but they're just being denied care or being abruptly tapered off of their care or things like that. And so there's a lot of concern about what's actually happening, what's being fed into the black box, whether those are proxies for race and other and other traits, or race, ethnicity, et cetera, whether race and ethnicity are in fact even being incorporated into it, and then the discriminatory effects that using those algorithms have on patients. And to be clear, those PDMPs were actually developed for law enforcement. They were not intended to be used for making drug prescription decisions, but we are in fact seeing that being, because of the way state law is set up, requiring the use of these now, we're seeing their mandates. So,
yeah, and I think that's something to emphasize too that I probably didn't in mine. You make a classifier to predict a particular outcome, and then you translate that into a clinical action. That also is a normative clinical medical ethics procedure. You're saying, well, based on this person being at high risk of death, we should have a goals of care conversation. So there's even in that picking what the outcome you're trying to classify is, and then picking the clinical action. That's something that clinical medical ethics needs to be involved in to avoid a program that was designed for law enforcement being now used to inform a physician who's going to change what they treat their patient's pain with, right? So I think that's another point worth emphasizing. So.
I had a quick question.
Yeah.
Related to having these decision-making supports sort of nudge people to take clinical action, Are there any safeguards that you think should be put in place so that clinicians don't just rely on that to say, well, the algorithm told me that this person doesn't need that, and so I'm not going to do it, even if based on their clinical reasoning outside of those different factors, they feel like it would be a worthwhile use of time to explore something like a goals of care conversation?
Well, yeah, I mean, I think the reasonable safeguard is always integrate this with your everything else that's going on with the patient, right? And that's why it's important if you set these thresholds too low and you're getting too many false positives, then there becomes alarm fatigue, people stop looking at them altogether. But you were asking more about when it's classifying a patient as not having the event and then not making them too certain. Yeah, I mean, that's always a risk. But I think the thing to remember is we should be comparing these algorithms to either treating none or like whatever the clinician would be doing without the algorithm. That's the relevant comparison. How much value does it add? And from a fairness perspective, is every marginalized group being lifted up, at least some amount? And the important thing is not you turn the algorithm on and one group's utility goes down. That's what we're trying to avoid. I think it's okay, this is something we've been talking about more with our colleague Govind Prasad. It's okay if all the boats go up, but one boat goes up like a little bit more than the other, right? I mean, maybe I think we have a moral obligation to make sure that the marginalized community's boat goes highest because we know they're starting from a lower point. But I think the important thing too to remember is yeah, the algorithm may have some false negatives, but how many false negatives do clinicians have in practice? Often, if it's worse, then justified to turn the algorithm on. So hopefully that answered the question.
Hi, I'd like to ask a political landscape question, if I may. This is directed toward Val. I was actually surprised to see, I hadn't thought this through, the consequences of the Students for Fair admissions decisions in Harvard and North Carolina having this downstream effect where they might will open the door to challenges to the federal government's entitlement to require and rely on certain categories in healthcare, in its healthcare laws. I'm wondering if you, what I know about those cases is that they were a long time coming. There were political advocacy groups dedicated to overturning those admissions practices. And I wonder if you see on the landscape any equivalent kind of advocacy in the works, especially targeting the Affordable Care Act, on which a certain degree of this depends.
Well, I mean, for one, I am pretty confident that the Affordable Care Act is perhaps not long for, or I imagine, I mean, we saw what happened the last time this President Trump was president. He tried to repeal it multiple times. They've claimed that they're going to again. So, whether this, Section 1557 is even relevant in a year or two, I would not be surprised if it's not, which therefore pulls back all of our anti-discrimination protections in healthcare pretty much. So, I mean, there's just that simple fact. But the question about whether SFFA is sort of extendable beyond the setting, I think absolutely. This is a concerted effort beyond the academic setting. Although we are seeing already cases in the academic setting. We see the lawsuit right now against Northwestern alleging discriminatory hiring practices in their DEI approach and those kinds of things. And a lot of these efforts aren't necessarily intended to actually eliminate the processes legally, but to stymie and instill fear in organizations and institutions that make efforts to address historic discrimination and structural inequities in their, whether it's in healthcare, whether it's in academia, whether it's in hiring, whether it's every setting, because it means that they're opening themselves up for incredibly expensive and lengthy litigation and public backlash.
And I'll just add, I was on the recent National Academy of Medicine committee that released the Ending Unequal Treatment report this summer, and we had several lawyers on the committee, and their primary concern was this legislation and the impact of what that meant for healthcare, particularly when there is descriptions of the collection of race and ethnicity data as junk science. So what that meant for our ability to even collect data on race, ethnicity, and language, what that meant for our ability to do healthcare equity research, and everything in between.
Yeah, I think there's the immediate threats are like, in the funding landscape, just less work about describing healthcare disparities and solutions to improve the population health of marginalized populations. Like, I think that's probably the more immediate overall risk from a research perspective. From a clinical algorithm perspective, I could see things like what the OPTN's done to correct the disadvantage Black patients had on getting onto the kidney transplant list. That under experiencing a lawsuit, I mean, it's a temporary restorative justice fix, even as designed, because right now, if you're Black, you're able to start your waiting time clock before you got listed whenever your kidney function went below EGFR went below 20, and that's the only racial group that can get that advantage. So nobody, even the policy designers, did not intend for that to be indefinite. It was just to correct for the effects of the EGFR, the race-inclusive EGFR algorithm. But I can see like efforts like that if they're noticed by the the right undergoing legal scrutiny, and the same laws being turned against them.
And if I could just add one other thing is that there are efforts to, so there are a lot of folks that are very fearful that anti-discrimination laws as they currently stand, both at the state and the federal level, are going to be pulled back under the next administration. But to the extent that they're not, we've already seen efforts, particularly at the state level, but there's also been pushes at the national level as well, to use anti-discrimination laws for sort of almost the exact opposite outcome and effect that they historically have. So, for example, a couple of years ago, Montana passed a law that expanded its state anti-discrimination laws, which cover sort of the typical, the historical marginalized populations, race-based, right, race, ethnicity, age, sex, et cetera, to also cover individuals who choose not to be vaccinated and classify them as a protected class in healthcare. So, and we've seen a lot of other states say, ooh, that sounds like a good idea. We should go in that direction too. So it's not just the elimination of anti-discrimination protections, but also the reusing or modifying them to serve completely different purposes.
I think just overall AI deregulation is something to expect too, right? So there will be very few constraints over what the government's probably going to be able to regulate. So I think that means that in our own institutions, we have greater and more obligations to understand how these things are working, to review, to understand the classification, understand get under the hood a little bit, and point out things so inadvertently we don't create algorithms that make marginalized groups worse off than not having the algorithm turn on at all. So I think that's a big real risk too, with like total lack of oversight or regulation, that inadvertent harm will be done by people who are working in healthcare systems who otherwise are well-intended.
Excellent presentations, all three. For all three of you, my big concern, and you sort of touched on this a little bit, is not necessarily the mechanics of all this, although I think that's problematic at times too, but the actual questions that are being asked and the uses of these tools. That it seems to me that the driver of it is primarily efficiencies.
Right.
And people, I work with children with disabilities and people who have, and are marginalized, they have always lost when we're driven by efficiencies or quality of life metrics, or that. All of this seems to me a bad idea.
No,
I mean, just to use your example, why don't every person going into the ICU get that
Well, this is a general
conversation?
hospital population, and I think there's downsides to triggering a goals of care nudge on everybody. I gave the example, if I broke my ankle, don't talk to me about that, right? So there are costs, but I think you're right. These algorithms are being designed and turned on by health system C-suites, right, who are thinking about nonprofits. So, but the positive case here is now, with the way generative AI is exploding, these tools are increasingly accessible to many, many more people. And designing an algorithm to make children with disabilities better off is possible now and more accessible, because the cost of doing that has dramatically decreased, right? And so it's not going to be something where only people who are really well-resourced, who are trying to create enormous financial returns, can design and implement generative AI algorithms. It can, even people who are working on the behalf of marginalized communities will have access to those tools.
But apropos of the structural racism that exists, I mean, children's hospitals get paid by Medicaid, which is 60 to 40 cents on the dollar for the same code. So you're putting these decision metrics into situations that are structurally unequal. And so the people making decisions for efficiency are going to be like, don't spend money on that, which is what our current system is, which is why there are few people going into pediatrics and particularly serving these communities. And so I think there's tremendous possibility of just pushing this further for the sake of efficiency.
Yeah, I think in the end of the day, like, the AI will be a tool, and it's not going to make those choices, those societal choices we made for us, right? Like that you're outlining. But I do think their accessibility of AI to a broader and broader group of people, we have to hope will empower the less resourced communities to catch up. Right? I think that's the optimistic case here. We can't be scared of it. You got to start using ChatGPT all the time, everybody. Seriously. And it's coming. It's going to be everywhere, ubiquitous in healthcare. We have to understand how it's going to be used and to try to modify our patient care, and we have to try to use it to advance equity, I think. I think
15 minutes over?
No, we're supposed to be done at 3:10. So
okay.
I think, thank you so much for your attention questions. The three of us are happy to answer additional questions, but we should definitely release you to the break at this point. Thanks so much.
Wow, go us. Thank you.